And now we come to case number 3. Case number 3 is a call to Mr. C. Dispatch, 71-year-old male having another one of his heart attacks. Literally what we got over the radio. En route, we got additional information. Patient is very short of breath, has a history of heart failure, which has caused several episodes of shortness of breath calls before. And the time is 1:18 in the morning. We arrived to find the patient in a finished basement accessible only by a narrow, steep stairwell. We can hear his rattling breathing all the way up the stairs. We arrived to find him fully dressed, sitting in an easy chair with his nasal cannula hooked to a large concentrator behind the chair. He is alert, anxious, but oriented. He is extremely diaphoretic and pale, and he is able to speak in 2 to 3 word dyspnea. His respiratory rate is 60 breaths per minute. He has an abdominal accessory pattern observed from a distance, and the airway rattle that I had mentioned could not be cleared by attempted cough. Breath sounds included crackles bilaterally, diminished in the bases, in fact absent in the right base. He had no wheezes. He also had a rapid and weak pulse. Patient has had sudden shortness of breath for about an hour. This came on while he was preparing for bed with minimal exertion. He's already tried 4 nitroglycerin tablets sublingually and has increased his home oxygen to the maximum setting. He's not able to cough anything loose, and he has a long history of congestive heart failure. He has no history of asthma, no medications that are bronchodilators, no nebs or inhalers, and he has recently been taken off his diuretics. He has no new peripheral edema and was feeling pretty well before this evening. Medications that Mr. C is currently on include Coumadin, Zestril, aspirin, a potassium supplement, aldactone, captopril, Lopressor, and insulin. He is recently taken off of Lasix and Lanoxin due to a high serum sodium, low serum sodium. So he's losing too much sodium. And he has no known drug allergies. So let's consider those medications. Coumadin is a clot inhibitor, often referred to as a blood thinner, often prescribed for people who have a high risk of clots, such as people who are frequently in atrial fibrillation. Zestril is an ACE inhibitor, most often prescribed for high blood pressure. Aspirin, a platelet inhibitor. Potassium, a supplement for making sure you have enough potassium after you're on diuretics. Aldactone, a different type of diuretic, different from Lasix in that it helps spare potassium in the body. Captopril is another ACE inhibitor, but that is specifically good for helping to protect the kidneys. Lopressor is a beta blocker, which helps to lower blood pressure by a different means, and also is responsible for slowing the heart rate, which in many cases can lead to a better cardiac output and therefore less congestive heart failure. And of course, insulin is for his diabetes. This patient received a limited assessment physically from us. We did put him on a monitor, which showed that he's got atrial fibrillation with a rapid ventricular rate. His vital signs, the rapid respiratory rate, a pulse of 140, and a BP of 146 over palp. In our pre-hospital care, as you might imagine, one of the first things we did was try to talk him into slowing his breathing down. This was made somewhat difficult, but he continued to try. We got an IV in. This was also quite difficult. While getting the IV in, we usually draw bloods, but this attempt had to be aborted so that we could float the catheter in. And the tape holding down the IV was very difficult to maintain, so we wrapped it with Curlax. We also called for extrication help. At one time, we were thinking if we get him feeling a little better, maybe he would step up the stairs with us. But very quickly realized that was not going to happen, and a rescue team was called from the fire department. He received from us 2 sprays of sublingual nitroglycerin and 80 milligrams of Lasix, and we apply the non-rebreather mask at 10 liters per minute. We then, with the assistance of the rescue squad, extricated him from the basement. Having no stair chair that could fit in the stairway, we used a rigid chair that we found in his home and bound him to it with a sheet. At the top of the stairs, a third nitroglycerin spray was administered, which seemed to give more improvement. He then received a rapid transport to the hospital after 31 minutes on scene. In the emergency department, they placed a Foley catheter. They provided a nitroglycerin drip. They gave him some more of this diuretic, Lasix, and they put him on a drug called cardizem. Cardizem is a calcium channel blocker, which is very effective at reducing the heart rate in patients with atrial fibrillation. Cardizem is also good for congestive heart failure in that it can improve cardiac output, particularly when the rate is so fast that there's inadequate ventricular filling. The following ABGs were obtained. He had a pH of 7.12, a PO2 of 80, and a PCO2 of 72. Now, to kind of review, normal pH is 7.35 to 7.45, so this number being significantly lower means that he is significantly acidotic. The PCO2 of 72 is much higher than the range of carbon dioxide, which is normally between 20 and 40 torr in the bloodstream. So 72 indicates that he has a respiratory acidosis. His pulmonary edema is worse on the right side, as just demonstrated by chest x-ray. This was the EKG. As you can see this rapid and irregular rate, it's no wonder that the ventricles are having a very difficult time of pumping blood efficiently out of the lungs. And even though he has high blood pressure from a lot of resistance in the arteries, it is not helping in any way to do anything but just keep the pressure up in the lungs, causing a flash of pulmonary edema. What this patient really needed, in retrospect, was more direct action to try to slow this heart rate. In addition, one treatment that would have helped a lot in the field that is now becoming available through all pre-hospital is bi-level positive airway pressure. In the emergency department, he was placed on BiPAP. He also received more cardizem to get his rate under control. The second set of blood gases showed some significant improvement. His pH is now 7.31, his PO2 is 93, and his CO2 is 47. With that, he was admitted to the intensive care unit feeling much better. So would you have treated Mr. C much differently? I think there are certainly some treatments available today. One thing that you'll point out from our treatment is that we did not hesitate to give him nitroglycerin. Nitroglycerin is not only recommended for people who have angina, but can be quite useful for people with congestive heart failure. They have a fluid overload due to the fact that the left heart cannot pump blood adequately from the lungs to the rest of the body. And by combining CPAP and nitro, you get a very good effect. Congestive heart failure begins usually with left heart failure. Left heart failure leads to increased pressure in the pulmonary circulation, what is referred to as an increased pulmonary wedge pressure. And from that increased pressure, we see that fluid leaks across the alveolar membrane from the capillaries. And this fluid is actually coming right out of the blood serum. This is pulmonary infiltration, which leads to pulmonary edema and makes it very difficult to breathe. The result is a diffusion deficit, with fluid blocking the absorption of oxygen from the atmosphere and the release of carbon dioxide from the bloodstream. Blood gases are not able to diffuse across the alveolar space correctly. As a result, many of these people suffer from shortness of breath that is particularly worse if they try to lay down. And frequently, people who have congestive heart failure will have episodes where they wake up suddenly in the middle of the night feeling very short of breath, a condition called paroxysmal nocturnal dyspnea, or PND. Sometimes the left heart failure causes more lung issues, and people who have lung disease and increased pressure in the lung will eventually cause right heart failure to occur. Right heart failure is different from left heart failure in that right heart failure, now the backup is toward the systems of the body that are bringing blood back to the heart. So you'll see enlargement of the liver, you'll see engorgement of the neck veins, and a lot of times pendant edema in the ankles, or if a person is bedridden, maybe in their sacral area. So we mentioned CPAP and we've mentioned BiPAP. CPAP refers to a continuous blowing of air into the airway, resulting in a continuous positive airway pressure. BiPAP is bilevel positive airway pressure. So a triggering device actually lowers the level of pressure against the airway during exhalation, but it still has some pressure there. This works very well to maintain oxygenation and ventilation in patients who have a wide variety of lung diseases, but primarily useful in pulmonary edema secondary to congestive heart. CPAP, if applied early enough, is an effective way to treat pulmonary edema and is a way to keep those people from having to be intubated. CPAP increases the airway pressure, allowing for better gas diffusion. CPAP allows the refilling of collapsed and airless alveoli. So CPAP therefore recruits more alveoli into the job of diffusion. CPAP thus buys time for us to see our medications do their work to help the patient breathe better. Another thing that CPAP does, it actually expands the surface area of the collapsed alveoli, allowing more surface area to be used for the exchange of gases. So you can see in this comparison here, a small alveolus only can diffuse so much, but an enlarged one can diffuse 10 times. CPAP is applied during the entire respiratory cycle, as opposed to BiPAP, where it's higher in inhalation and lower in exhalation. It's used as a tight-fitting mask applied over the mouth and nose, and the patient is assisted into an upright position for maximum effect. The lowest possible pressure should always be used with CPAP, and the high pressure, you have a risk of barotrauma such as pneumothorax, a pneumomediastinum, or even just a drop in blood pressure due to increased pressure that the blood would have to go against in order to fill the ventricles of the heart. Our goals in using CPAP are to increase the amount of time that oxygen is inspired, to decrease the workload of breathing, and as a result decrease their need for intubation, shorten their hospital stays, and diminish their patients with signs or symptoms of pulmonary edema should be a first candidate for CPAP. Patients with exacerbation of COPD, even with wheezing, could also benefit from CPAP, and patients must be alert and cooperative. Other criteria is that the systolic blood pressure should be greater than 100, and they should not be nauseated or vomiting. They should not have facial trauma, and they should not have chest trauma. So, after talking about CPAP and BiPAP, I'm quickly going to move on to our next and last case. This is case number 4, Mrs. P. Case number 4, our crew is the backup crew as our primary ambulance is already involved in another call, and as a result, we're actually called in from home with about a 10-minute response time. Our crew 2 is needed for an 85-year-old female with shortness of breath. It's 2:02 in the afternoon, and it's about this same time of year. And as we look at the scene, we see that this patient is inside their kitchen, somewhat in a tripod position, already using her home oxygen. She's an obese woman, and the period of time, as I mentioned, is early spring. There have been recent rains, a lot of wind, and smoke from distant forest fires can be smelled in the air. We find that she is alert, oriented, acutely anxious. She has been breathing fast. She has grunting respirations. In other words, at the end of each exhalation, you can hear this little grunt. Breath sounds are clear and equal. There are no crackles. There are no wheezes. She has a regular pulse. Our patient has a history, on exam. We find that we're not able to get a SAT because our backup ambulance seems to have a broken SAT monitor today. Our ECG is checked, and our cardiac monitor shows a sinus rhythm with no ectopy. Patient's vital signs are pulse rate of 90, BP of 140/70, and respirations of 36. Patient says she has felt short of breath for many days, worsened upon waking up this morning. 3 albuterol nebs today were used, and they really didn't seem to help. I asked her if she thought that the recent smoke was what started her shortness of breath, and she seemed to think so since it had been about the same time. She's had a cough with phlegm, which she can't seem to bring up, and she denies any chest pain, chills, fever, or respiratory tract infections. So case 4 continues. She has a history of non-insulin dependent diabetes. She does have a history of CHF, asthma. She's had chronic back pain for quite a while, and she has GERD, gastroesophageal reflux disease. She's on quite a few medications, and I'll let you look at this list here and look that over. Her newest medications are the Celebrex and the Prilosec. Mrs. P has no known drug allergies. I always like to reflect on medications. This is something that is just part of taking a good history. Why do these people take these meds? It's not unusual to see somebody of this age on quite a few medications, but this seems a little bit complex. So isosorbide is a nitrate, and as a result, it's usually given for people who have frequent inguinal pain, as well as who maybe need a little better coronary perfusion. So this is a person with coronary vascular disease. Metoprolol is a beta blocker, frequently prescribed for high blood pressure. So is Cozar, prescribed for high blood pressure, but it works as an angiotensin II inhibitor. So it actually blocks that pathway of enzymes that start from the kidneys that tell the body to raise blood pressure when there's insufficient fluid to the kidneys. And this is a mechanism that is often blocked when we're trying to treat high blood pressure. In addition, she's on Lasix, which is a potent diuretic. And since she's going to be peeing a lot, she tends to lose some electrolytes that way. So it's understandable that she's on all these supplements such as potassium and calcium and magnesium supplements. Norvasc is a calcium channel blocker, which is a completely different mechanism by which we can relax smooth muscles in the blood vessels and thus really reduce blood pressure that way. Glyburide is prescribed to people who have type 2 diabetes. It helps improve the absorption of glucose and insulin into the tissues. And of course, the fact that she's on continuous oxygen tells you that her lung disease has been pretty extensive and she's been hypoxic for a considerable amount of time. Prednisone is a strong steroid medication and usually prescribed only for people with fairly advanced disease of an inflammatory nature. The Celebrex and the prednisone together make me think that her joint disease is probably the cause of her back pain. And then the Prilosec, of course, is now over-the-counter, a medication used to block the production of acid in the stomach. So what we did, first of all, was coach her to slow down her breathing, try to improve the effectiveness of her breathing by keeping the rate under control, encourage her to use her diaphragm to breathe. We gave her a Combivent neb, mainly to help calm her down. We got her quickly to the ambulance. We were a short distance from the hospital. I have to admit I had second thoughts about giving her that Combivent just because I did not detect any signs of bronchoconstriction. We started an IV saline lock, and we drew bloods while en route to the hospital. Once that was vitals, and patient seemed to be less anxious. Her new set was a respiratory rate of 24, pulse of 84, and regular, and respirations were 140. She had no cough. She was not. Once she arrived at the emergency department, she was placed back on IV Bumex. Similar, they found that she had a significant amount of fluid in her lungs, and a Foley was placed, but very little urine was produced. Chest X-ray was taken, which showed that in fact she did have significant bilateral pulmonary edema. She had had a similar X-ray done about 18 days prior, when she also came in thinking she had asthma, but also had some increased pulmonary edema. This was a much worse case than then. Her blood sugar was 168, and when they did other lab tests, they found that her BUN and creatinine, both indicators of kidney function, were 2 times the level that she'd had last time reported. This indicates worsening kidney disease. So this is a patient who has had some kidney failure in the past, and the fact that she's got chronic kidney problems makes it more important for her to be very careful about her medications. The increased back pain is what led to her prescription of Celebrex about the time of her last visit. Other nonsteroidals were tried, but they were never as effective. The Celebrex finally helped to ease her pain a little bit. So she was admitted to telemetry. A nephrologist was consulted to see the state of her kidneys. Early the next morning, she was transferred for dialysis. And this patient is going to be on dialysis 3 times a week for the rest of her life. She now has no kidney function. She had 4 other COPD and CHF exacerbation calls over the next 14 months as I reviewed her records. And one of the things that we note here is the kidneys played a major role in why she had a fluid backup in her lungs. It wasn't so much that there was a rapid onset of a new arrhythmia or weakening of the left ventricle, but in fact the kidney failure that contributed to her increased pulmonary edema. I'm now going to have you take the quiz on these cases 3 and 4.